I would like to thank Kishore. It is because of him that I have come here, and also Dr. Powar. I have been associated with Dr. Powar when he was in GMC Nagpur, and he had his national conference then. I was the one who made his website and hosted it on the MUHS website. So we have a long association of working during conferences. Now with this thing in background, I was finding it very difficult to deal with this particular topic of how to finish it off in 45 minutes, because each point of this particular topic covers a whole CMA. So I would like to distribute it in various different small chapters and try to cover it as fast as possible. How I am going to cover it, I would like to tell you first. I would like to tell you what an ICU is. Then I would like to deal with what are the infections, types of ICUs, then the infections in ICUs, sites of infection, pathogen, antimicrobial resistance, and so on and so on and so on as we go ahead. So let us start with it. The first thing which we'd like to know is what's an ICU. ICU is an intensive care unit. It is defined as a specially staffed, specially equipped, separate section of a hospital dedicated to observation, care, and treatment of patients with life-threatening illness, injury, and complications from which recovery is possible. This last statement is important. Recovery is possible if we take proper care in ICUs. The history of ICUs dates back to 1950s when it was first tried in a polio epidemic, and then slowly and steadily it started covering all the serious patients who required ventilation and a close care. These are the types of ICUs in which we would be dealing with, because depending on the types of ICUs, the infection varies because of the factors like what intervention you are having to take in a particular ICU differs, and therefore the infections, the organisms also change with the ICU which you are dealing with, and therefore I would be dealing with each separate ICU in spite of my topic being just restricted to SICU and ICU. I don't think that would be enough. We'll have to deal with almost all ICUs because the pattern of organisms responsible for that particular infection in those ICUs differ. Here I would like to put one more important thing across here. That is, if we start enumerating the organisms which cause infection in ICUs, that would be a very fallacious thing, because the organisms which are isolated depends on, as I told you earlier, the type of ICU, and also depends on the geographical location in which the ICU is placed. And therefore, it's the responsibility. I think this is the best place where a microbiologist has a role in administration of the hospitals, because each ICU of each college or each other institution, any institution, is a very different milieu. It's a different geographical entity, and therefore the infections in that particular place are totally different than what literature cites. And therefore it should be a function of each microbiology department to have a very comprehensive study of what are the infections in that particular ICU, particularly then follow it up with the antibiotic sensitivity pattern, and then with the help of administrators come up with an empirical treatment for that hospital. Right now what is happening is we are depending on the empirical treatment of the studies which are carried out in places which are not our places, and therefore we generally fail in the first 48 hours in choosing the correct antibiotic. And therefore I think now, as an administrator also, I think microbiologists should help an administrator to formulate a policy. Many places it is there, but what I have seen up till now is that generally it is derided and is not given importance. Clinicians, I think clinicians are sitting here from Solapur college, and they would appreciate that it's the patient and his malady which encompasses all their thoughts, and then coming or formulating a policy and then depending on a policy of a college becomes a very difficult thing for them. But I think this change in thinking is very essential, and if that is the take-home message of this particular lecture, then I think the job is served. So when we go back, I think the first thing we should do is we should talk with the dean and tell him that we have to formulate a policy for our ICU, because the thing which you are doing is totally wrong, and you are depending on the empirical values which is something which is based on the studies which are carried out in some other place, and you are applying it here. Because the first thing I would like to emphasize on all of you is that the organisms which are isolated from a particular place, from a particular ICU are its specific organisms. Further, they change with time, and therefore what you did in 50s cannot stand in 60s and so on. So we'll have to change that. If you go on, depending on textbooks are generally referring to studies which are almost 30 to 40 years old, and therefore I don't think we can depend on them. Therefore the best thing is, at the end of this lecture, if we make up our mind, go back to our places and then get the things done, I think the job is over. So come on, let us now go to other different types of ICUs, and the next thing, the infections in ICUs. Patients in intensive care units have a higher risk of acquiring hospital-associated infections than those in non-critical care areas. Up to 45% of hospital-acquired infections occur in ICUs, although these patients occupy only 8% of hospital bed. This is a very important statement, because ICUs generally all over the world, they have a bed strength of 8 to 10% at the most. Even in advanced countries, you have only 8 to 10% of beds which are dedicated to ICUs. But then the infections which occur there are extraordinarily more than what happens in a general ward. ICU acquired infection rates are 5 to 10 times higher than hospital acquired infection rates in general ward. ICUs are an area of considerable antibiotic use, in which antibiotic resistant organisms are prevalent. As we move ahead, we are going to discuss this problem also of antibiotic use in ICUs. Particularly, I have made mention of the empirical use which we go on. Empirical, I would like to clarify this. I generally try to do that, this explanation of this term empirical, always wherever I find the chance. People mistake empirical as what they think according to their own experience. That is what people generally think, that is the meaning of empirical. Because I have an experience of 30 years, and therefore whatever I say is correct, and therefore it is empirical. But it's not like that. Empirical study, there are empirical antibiotic choosing is dependent on scientific studies which are carried out, which tells what are the organisms which are isolated and what are the drug resistance pattern of those organisms, to which antibiotic it is sensitive, and then utilizing that particular knowledge before you do culture and sensitivity is empirical treatment. So this should be clear, and therefore we have to take care of those empirical treatment. Microbiologists, it's the microbiologist's role. Then infection, ICU patients have infection. This can be divided into 3 groups. One is which you get from community acquired infection, hospital acquired infection before transfer to ICU, and ICU acquired infection. We will be depending, I have painted it red simply because we are going to deal with only that one as we move ahead. Now this is a very important thing which we all have to understand, is the stay of more than 24 hours in the ICU, which increases the probability of you having infections. So just being in ICU is enough to get infected. This has to be understood very clearly, and this has to be explained to the people also. It's an informed information which you have to give to the patients also, but I don't think anybody does that. What are the sites of infection? Sites of infection are lungs, percentage is given there, other respiratory infections. So lungs covers the most important site of infection. I think that should be very clear. If you go in logically, you will understand very clearly why that is the case. Because the whole concept of ICU started with use of ventilators. So that is bound to happen, because this is how it would be. Because you use ventilators in ICUs, and therefore, and it is ventilators which led to development of ICUs, and therefore that is how we are going to get maximum infections in lungs. Then urinary tract and bloodstream. Again here I think we should give an importance, and we should start thinking from that point of view, why UTIs and why bloodstream infections? Simply because you are having interventions. You are entering sterile spaces. Because you are entering sterile spaces, you are bound to carry infection there, you are bound to carry organisms inside, and therefore the infections in this particular areas are more. These are the other sites of infection. Again, I think you would appreciate why we have those infections there. These are the other sites of infection. If you see this graph, it would be very clear that the maximum infections are pneumonia, then bloodstream infections and UTIs. Others have a very small chunk of infections. As we move further, we'll emphasize on those reasons of why this happens. I'm sure that you can't see anything. I tried my best. But okay, I would tell you, I think telling which organisms cause infections to microbiologists is superfluous, and therefore I would just like to enumerate a few, and then I'm sure you know it because we can't read anything there. Primary bloodstream infections, Coagulase negative Staphylococcus aureus is the most common, then it's Staphylococcus aureus, and then all gram-negative bacteria, and more importantly nowadays fungi, fungi particularly Candida albicans and other Candida are increasingly being accelerated from infections of lung. Pneumonia, again you would see that Staphylococcus aureus is common, Staphylococcus pneumoniae and others are less common. More common again are gram-negative bacteria, and fungi you have Candida. Urinary tract infection, I think again the same thing is there. Coagulase negative Staphylococcus aureus and the gram negatives and Candida. I think microbiologists don't need to focus on this more. We know all the organisms. We come again to antimicrobial resistance in ICU pathogens. This is a very big problem, and again I would like to take your attention to the second statement which I have put there, that the prevalence can vary enormously depending on the geographical location as well as the location amongst the ICU types. And once we understand this very clearly, it again increases our importance in hospital care. Rates and prevalence, the EPIC study, that's the European study, a long time back, tells us that 20.6% is the infection rate. Incidence from a US study, US people they won't like to follow how Europeans do, and therefore they go in for per 1,000 patient days, and that also tells you that it's very high in ICUs. Then what the rates and prevalence of ICU acquired infections, what are the most significant factors for that? I think this I made a reference earlier and like to make a reference again on it. It's the invasive devices which lead to all these problems. Mechanical ventilation being the first, central venous catheters being the second, and urinary catheters being the third. Then we'll have to understand this particular important thing also, because the use of devices is different in different ICUs, the infection rates are also different. There are certain ICUs where you have to have ventilators, and therefore the infections of lungs would be common. Other ICUs you would have bloodstream infections which are more common, and still others where urinary catheterization is a must in each and every patient, and therefore there the infections of UTI would be common. So I think if we make up our mind of understanding this particular basic concept, taking care of the hospital ICUs would become easier for us when we go back. This tells you how all these three instruments, invasive things, invasive interventions which happen are seen in different ICUs. Medical surgical ICUs. Medical surgical ICUs are the ones where you cannot specify a medical case or a surgical case. Each of them don't make more than 80%. So it's called as a medical surgical ICU where both patients are admitted. And there also we see that instrumentation and interventions, invasive interventions are commoner in teaching hospitals. And therefore infection rates are also higher in teaching hospitals. This has to be understood as compared to non-teaching hospitals. Then I have given all the device utilization ratios in all the ICUs which are there, surgical, medical, coronary, pediatric, cardiothoracic and so on. So comparing intensive care units, now I think it's a very, you are going to take that take-home message very clearly now. I've repeated it at least 3 or 4 times, that the infection depends on the type of ICU. Why does it depend on the type of ICU? Because the interventions, invasive interventions differ as per the ICU. Further, each ICU has its own geographic milieu, and therefore the organisms and the type of resistance which we get is different with each and every ICU which we have. The type of infection and the pathogens vary between different ICU types. A combined medical surgical ICU, the first one which we are going to deal with, is where neither medical nor surgical patients represent more than 80% of total patients in the unit. And if we see very carefully, all the medical colleges basically have this type of ICU in our place, because any patient who comes there, maybe a gynec patient or any patient, he has to be put in ICUs. Nobody listens. There is a lot of fight between medicine people and surgery people and gynec people, each one trying to kick the other patient out because it's our ICU, it's my ICU, it's a medicine person who is taking care of the ICU and all those things. Therefore, I thought that the anesthesiologist should look after all ICUs, so these fights would stop. I've tried to make it in my hospital, but there was a very severe resistance to it. Surgical intensive care units, nosocomial pneumonias constitute 43% of hospital active infections in SICUs. Ventilator-associated pneumonia rates in general ICUs are higher. General SICUs are higher than cardiothoracic ICUs, but lower than neurosurgical, burns, and trauma ICUs. The second most common infection in SICU is UTI, it's 25%. Then bacteriology of SICUs has changed over time, and this is common for almost all ICUs, where Enterobacter, Acinetobacter have become commoner. Candida has gained entrance almost everywhere. Gram-negative bacteria and Enterococcus have replaced S. aureus, the most common isolate responsible for surgical site infections, almost everywhere. In pediatric intensive care units, bloodstream infection is most common. Urinary catheter use is markedly lower than in adult ICUs, and gram-negative bacteria are more frequently reported as causing primary bloodstream infections in adults, and Enterobacter species is most common. Viral infections are also significantly common. Problems of antibiotic resistance, particularly vancomycin-resistant enterococci, is less in pediatric ICUs when compared to adult ICUs. The neonatal ICUs are also a very important component of each and every hospital, NICUs. NICU infection rates are reported in range of 6 to 25%, and particularly important is that a low birth weight baby is the one who suffers the most. Primary bloodstream infections are most frequent in hospital-acquired infections in all birth weight groups. All aspects of immune functions, as you know, are immature and neonate, and therefore has a chance of getting infected with otherwise normal flora of other persons. Fungal infections are also very common in a neonate. The risk factor include broad-spectrum antibiotic use, intravenous fat emulsions, and use of central lines. The interventions which we undertake to save the lives of persons. Catheter colonization rates are significantly greater than those reported in adults, and I think I have already given the reason for that. The reason being that the immune system of the neonate is very immature and cannot deal with it, and therefore catheter colonization is more, and consequently bloodstream infections are common. Gram-positive cocci are most common nosocomial pathogens in neonate. I think this particular statement is also very important to be understood, because other places what has happened is that gram-positive bacteria are replaced by gram-negative, but not in a neonate, because there is nothing giving resistance to it. So that is a big issue in this neonatal infections. Group B streptococci were isolated with 40. This particular fact I have importantly kept there to show that group B streptococci, if they are acquired, they cause infection when they are acquired from the mother. Most of the infections, 46% of isolates, if you get it from the mother, are of group B streptococci, and Coccus negative Staphylococcus aureus is one which is very common when it is non-maternally acquired infection. Then trauma intensive care units. Here, I don't think many medical colleges have such a thing which we have, but then it's an important thing, because 40% of the patients with traumatic injuries are admitted to ICUs. Sepsis is a major cause of mortality in these patients, and device utilization rates are among the highest. I think that directly tells you that as device utilization is maximum, you are going to have maximum infections in trauma intensive care units. So in a cohort, we had a study of 10,000 patients. The rate was 20%. ICU acquired infections were 4 times common. Now this is a very important thing which I would like everybody to focus on. Generally microbiologists think, and they are taught in the MBBS, that skin is the barrier which is very important, and once that barrier